This student is portraying a 65-year-old patient with neurological diagnosis of MCA-CVA. The commentary for this analysis will focus on the left affected side of the patient's body. It is apparent that the patient has an asymmetrical posture with her head and trunk leaning towards the right unaffected side. She holds her left upper extremity in the same pattern as mentioned in the sit-to-stand transfer analysis. Her left arm is held in elbow, wrist, and finger flexion and is slightly abducted from the body as the spasticity increases as she struggles with the complexity of this GAIT task. Although the patient's left arm is spastic, the left leg is paretic. This combination leads to dyscontrol issues during ambulation as seen in the following video clips. We shall start with analyzing the stance phase of the left lower extremity. The patient has an adequate heel strike and dorsiflexion at initial contact. At lowering response, the patient continues to have her weight shifted to the right with the trunk in flexion. But once the patient begins to accept some weight on the left lower extremity, the left knee hyperextends. It appears this hyperextension is due to weakness as the patient is able to achieve adequate plantar flexion and the lower extremity appears to be more paretic than spastic. In terminal stance, the body advances over the left foot, but again in an asymmetrical pattern, with decreased weight bearing on the left extremity. The left ankle, knee, and hip are in the correct position to advance to the swing phase. With analysis of the swing phase, the left lower extremity does appear to be able to achieve toe off to prepare for the initial portion of pre-swing. The weight shift from the left to right is minimal as the patient's center of mass has been distributed more over the right leg and quad cane during the preceding stance phase. At initial swing phase, the patient continues to have an asymmetrical posture, and her force production to propel her left affected extremity is poor. The acceleration of the left affected extremity is poor in mid-swing, and the patient is not able to swing the left leg equal to that of the right leg. She does have an adequate clearance of the toes and does not need to compensate for dorsiflexion or hamstring weakness. At terminal swing, the left affected leg lands with the foot flat and has little to no heel strike. The trunk minimally shifts and maintains the same asymmetric pattern consistent with hemiplegic gait. The patient displays a host of dyscontrol issues. The patient has a primarily flexion synergy pattern of the left upper extremity but displays weakness of the left lower extremity. The patient displays improper timing and sequencing of the left affected limb. The patient is also asymmetric with her center of mass shifted towards the right over her right leg and right-sided quad cane, as if avoiding the left lower extremity. The focus of the next two treatment sessions will be improving symmetry of the gait pattern by improving weight acceptance to the left lower extremity while also working on quadriceps control and proper sequencing of the left leg during the entire gait cycle. Improving the symmetry of the gait pattern promotes efficiency of energy expenditure. In this first treatment session, the patient is placed in the parallel bars and is instructed how to participate in this activity. The goal of this particular session is to begin to gain control over the left quad during weight acceptance of the stance phase. The patient is instructed to turn out her right foot, which will cause her body to shift her center of mass to the left to allow turning the right foot out. As she does this motion, the therapist is at the knee, guarding the knee to prevent buckling and hyperextension, but also facilitating the left quad to activate during this weight transfer. The patient is also giving verbal cues to maintain erect posture and tapping on the left trunk and hip extensors as needed. The patient continues to perform this activity until adequate knee control is achieved and the manual contact is lessened. The therapist behind the patient is assisting in helping the patient move laterally and symmetrically from the pelvis and trunk. Her assistance is also gradually lessened as the patient is able to control the motion independently. Next, the patient is progressed with taking a step with the right leg forward and backward as would be normal during the swing phase of the right limb. The left leg is again braced at the knee to support the knee during weight acceptance. The therapist behind the patient is again assisting with symmetry of the weight shift to the left at the pelvis and trunk. Manual contact is lessened as the patient regains control of the left quads and is able to perform the task independently. Another progression to this task would be having the patient step up with the right leg on a step while the left lower extremity remains in extension. During this session, it is expected that the patient will gain control of the left quad and be able to decrease any insecurities of weight acceptance on the left limb. Practice continues in the parallel bars by putting several steps together while maintaining the proper gait mechanics during stance phase on the left and appropriate symmetrical weight shifting with improved posture. This second treatment session uses a body weight supported treadmill. This type of technology allows the session to focus on a multiple of issues. The issues to be addressed in this treatment session is the asymmetry of gait caused by decreased weight shifting and weight acceptance to the left limb during stance phase, but also the uneven step cadence and step length. The patient is strapped into the harness and secured. Initially, the patient's body weight was unloaded 25%. Ranges of unweighing are not homogeneous in the literature. This particular range was most appropriate for this patient considering her higher level of functioning. Higher ranges of unloading may be needed for lower level functioning patients. The therapist is sitting on the affected side of the patient's body. The treadmill was increased to 1.3 miles per hour during the session. Another therapist was behind the patient to facilitate weight shifting to the left side as well as facilitate upright trunk posture with tapping and stroking. The therapist at the leg is giving manual assist to prevent buckling or hyperextension of the left knee during weight acceptance of the stance phase. She taps on the quad to facilitate an active contraction. Also, the left limb is assisted in moving to the appropriate step length and sequence in relation to the right limb. The session continues with giving the patient verbal and tactile cues to promote motor control of the left quad and weight shifting to the left limb. Gradually, manual contacts and weight support is lessened as the patient gains control. The session begins at 5-minute intervals and time is increased as the patient tolerates with a goal of 30 minutes. Cardiovascular vitals are monitored before, during, and after the session. Once the session is complete, it is ideal to see practice of gait on level surfaces to enhance carryover. The therapist expects to see improvement of symmetry, weight shifting to the left limb, and decreased hyperextension of the left knee. Also, with work on the treadmill, increased gait speed and equal step length are expected as these issues were also addressed while focusing on the main problem.